Welcome to another live webcast of the International Oral Lichen Planus Support Group. I'm your moderator, Art Upton, and I'm joined in the studio today by the co-founders of our group, Dr. Terry Rees and Dr. Nancy Burkhardt of Texas A&M University, Baylor College of Dentistry. Our special guest today will be joining us live via Skype from his home in Baltimore, Maryland. He is Dr. James J. Sciubba, professor, retired of the Johns Hopkins School of Medicine, the Milton J. Dance Head and Neck Center, Greater Baltimore Medical Center. Dr. Rees will be introducing you a little bit more to Dr. Sciubba in just a moment. First, for the inevitable housekeeping segment, you will be able to ask questions today, and our guests and our hosts will answer as many as possible during the discussion portion of the program after our guest's presentation. You may enter your questions in the chat window just to the right of this viewing window. After our guest's presentation, he and Dr. Rees and Dr. Burkhardt will, as I mentioned a moment ago, be answering as many of your questions as possible during the session. If for some reason you do not have your concerns addressed today, your questions will remain on this page, along with the recording of the webcast for about a month, and one of the doctors will provide answers during that time. The chat questions will appear after the webcast is over as comments below the viewer window. Don't forget our web address. After the 30-day period, you will be able to find this webcast, even after that, on our website. And our new website address will be having back up on the screen at the end of the session. Now, when you go to our website, we just want to mention one thing for you, please. Notice that on every page you will notice a Give Today button. Please be as generous as you can to help us keep this service available to you and for free. Everyone involved, production crew, guests, everyone, donate their services for free, but there are expenses involved in producing and recording and publishing these webcasts for you. So please visit our site, click the Give button, and follow the on-screen instructions for sending us a donation, regardless of how small. And please be sure to designate that you want your donation to go to the Oral Lichen Planus Support Group. With that said, I'll turn the rest of the webcast over to our hosts, Dr. Terry Rees and Dr. Nancy Burkhardt, the co-founders of the OLP Support Group. They'll have a few words for you, and then we'll introduce our guest for a brief presentation, followed by a discussion and answering some of your questions. Dr. Rees.
Thank you, Art. Well, we want to welcome all of you to another chat session. It's hard to believe that it's been almost 17 years since we started doing these from time to time. And we grew up first using the computers and trying to answer questions that people ask us on the computers, and that was very labor intensive. Today we've gotten a little more sophisticated, a lot more sophisticated. We're very honored to have Dr. Sciubba as our expert today. He is a world-renowned expert in a variety of oral pathologic conditions, and he has special knowledge in oral lichen planus. So we know that this is going to be a wonderful presentation, and that's kind of the format that we will follow today. Dr. Sciubba will have some comments to make, and then we'll spend the remainder of the time with questions and answers. As Art said, we probably won't have time to address all of those, but we will get back to you on those questions sooner or later. And with that, I'll turn things over and let Nancy say hello to you.
Hi, everyone. First of all, I want to wish everyone happy holidays. We have a lot of festivities coming up. Dr. Sciubba was a guest early on. We've been doing this since 1997, as Dr. Rees just said. And he was a guest early on, so this is new for him too. He was one of the typists with the scrolling and everything that we did early on. So I think this is going to be a great presentation. I look forward to your emails. I get emails from you periodically, and if you have any questions at any time, whether it's related to the presentation today or any other questions that come up about your oral lichen planus or your family member, please just contact us. We'll be glad to answer it and get back to you. If we don't know the answer, we will find someone who does. So with that, I'm going to turn this over to Dr. Sciubba, and we look forward to his presentation.
Lichen planus has been recognized for many years, going back to the late 1800s by an English physician, Erasmus Wilson, who coined the term lichen planus. Later, the details of the disease began to be worked out, and particular features were noted as striaform lesions, and these are known as Wickham striae, which many people use to identify the clinical manifestations. While this particular focus is on oral lichen planus, we must not lose sight of the fact that lichen planus affects many different places in addition to the oral cavity, and these include the larynx, skin, the scalp, the nails, the esophagus uncommonly so, and the anogenital region in a fairly regular fashion. While a small percentage of the population is affected by lichen planus, 1% of 350 million people is a lot of lichen planus. Most of our patients are women, and most of the time, lichen planus presents on the skin, and many of our patients with oral lichen planus have concurrent skin lesions as well. The duration of lichen planus can vary from a few years to a few decades, and as we will see in the next few minutes, it will show various forms of clinical presentation. Up to a third of my patients and patients in general with oral lichen planus have concurrent or concomitant skin lesions at the same time. Most of the patients with oral lichen planus will not have cutaneous disease, but most do. And importantly, we must keep in mind that lichen planus can affect many different locations. When it involves the gum tissues, lichen planus can be discriminative in that it shows the tissues to be very friable and fragile. They will oftentimes peel off, and the word discriminative is used. And if you hear the term discriminative gingivitis, lichen planus is one of the reasons why you can get discriminative gingivitis, in addition to a few other diseases that are similar to, but not the same as, lichen planus. Importantly, lichen planus takes many clinical different presentations. The lesion in the upper left is the more classic reticular or striaform form of lichen planus. Where you see the teeth or dentition, you can see the gum tissue here being very red and inflamed. This is atrophic or erosive lichen planus. The lower left figure, it shows an ulcer surrounded by white areas. This is erosive lichen planus, and these tend to be very bothersome. And the lower right lesion is more what we call hypertrophic or later stage lichen planus. There are other forms as well that are discussed predominantly in the dermatological literature and less so in the oral literature. I call your attention to the fifth line down, something called pemphigoides. There is an entity that some people use titled Lichen Planus pemphigoides, where there's a degree of overlap between our condition, lichen planus, and another similar condition known as pemphigoid. And the differences can be subtle, and they can only be separated by a laboratory analysis. So classically and typically, lichen planus is on both sides of the oral cavity, usually on the cheek, inside of the cheek linings to begin with. You can see these white striae or lines that tend to intersect and overlap and branch. And more importantly, and I put an asterisk next to the term several patterns, in that you can see erosive lichen planus, atrophic lichen planus, reticular lichen planus, all at the same time in our patients. So you have to be aware of the variable degree of presentation. Most patients at a point in the evolution of this disease will show the reticular lesions that I showed you earlier. A smaller percentage will show atrophic lesions, and yet a still smaller percentage will show erosive disease. The latter two, atrophic and erosive lichen planus, those tend to be the more symptomatic and bothersome ones. An important point, I think, to recognize and appreciate is that lichen planus can last for a very long period of time, especially in the mouth. Skin lesions oftentimes will fade away or burn out, as it's called, within 4 to 5 years. But oral lichen planus tends to be more persistent, sometimes over decades rather than simply a few years. Location and site frequency, the cheeks in particular, the gum tissues, the top and side of the tongue, and less commonly so on the hard palate. The most common form is the reticular form, followed by atrophic lichen planus, and then somewhat less commonly erosive and ulcerative aspects of this disease. Something important to understand is that lichen planus is not a static disease. It is a very dynamic process. It will change its appearance and symptomatology over time. Patients who are being treated, who may be under very good control for months, if not years, suddenly will have a flare-up, and for no apparent or good reason, and that has to be dealt with. So the initial stage, 6 months to a year, patients oftentimes will complain about some symptoms or sensitivity to their dentist, perhaps, but minimally so. The dentist, in turn, may see lesions that are red or white or eroded, and that will call attention to the presence of this disease, leading to, ultimately, its diagnosis. The intermediate stage shows obvious reticular lesions, as we've seen a few minutes ago. You'll see areas that tend to be quiet or asymptomatic, and other areas which are more red and inflamed and quite bothersome. The times that Dr. Reese and Dr. Burkhardt and I see our patients, many times they'll show erosive disease, where the surface of the mucous membranes tend to be very thin. Actually, the surface may even break apart and be eroded or even ulcerated. These are very problematic and demand treatment. Subsequent to the later phases of the intermediate stage of the disease, you can sometimes see brown surface alterations, which is known as post-inflammatory pigmentation, which oftentimes will signal a decrease in the intensity of this disease. The late stage of this disease can last for many years, and as a result, we can often find a thinning of the mucous membranes. The top of the tongue or the dorsum of the tongue will show you loss of papillae. It'll be more smooth rather than more like a furry surface of a cat's tongue, so to speak. The gum tissues can be smooth and glassy rather than stippled. And a characteristic finding in late-stage lichen planus, in the back of the cheeks, where the cheek and the lower gum tissues meet, you will often find a loss of what we call the attachment and the onset of periodontal problems in this same area. So there are 3 stages of this disease: the initial stage of short duration, the intermediate phase, which can last for several years, and then the late stage, which goes on for years after that even. So chronically, we can see scarring. We ultimately see resolution of the inflammation. With that, we see thinning of the mucous membrane, smoothing out of the tongue, scarring on the inside of the cheeks, especially further back toward the oropharynx. We see loss of the fold, the mucobuccal fold, where the cheek and the gum tissues meet. And as I said earlier, you may see some pigmentation in the cheek. A colleague of ours named Dr. Drury Eisen coined the term vulvovaginal gingival syndrome. Written many times, we can find concomitant or concurrent genital disease along with oral disease, where the gum tissues are involved, as well as the mucosa over the vulva and the inner aspect of the vagina. And this can lead to significant symptomatology, where the gynecologist must be brought in to the management team. We know that there is a subset of lichen planus patients who have particular genetic qualities which make this a more likely occurrence, but this, in fact, is the minority of women with this disease. So with vulvovaginal, we find intense redness or scaling of the gingiva, and it can involve not only the gingiva but the inner aspect of the cheeks, less commonly on the tongue, and even less commonly the hard palate and floor of the mouth. one of the things we face clinically many times is determining whether or not drug therapy or other conditions may be helping lichen planus establish itself. And in that case, we call these lichenoid drug eruptions. And many drugs that are in common use every day, including antibiotics, antihypertensives, those people with blood pressure problems, antidepressants, those with diabetes, certain forms of diuretics, particularly the thiazide drug class, all can produce lichenoid lesions, which tend to fall under the overall umbrella of lichen planus. But there's a long, long list of drugs that one should be aware of as potentially being involved with the elaboration of lesions. So here will be a series of lichen planus. This is the classic reticular lichen branching surrounding some areas which are a little bit thin and red. This is a more classic, heavily keratinized or reticulated form of lichen planus, again involving the inner aspect of the cheek, extending into the mucobuccal fold right next to the jaw. This is a combination of a little bit of atrophic lichen planus, but broad, widely based reticular disease involving the cheek, and this is usually on both sides in a symmetrical distribution left and right. A favorite place for lichen planus to develop is what we call occlusal line, where the trauma of routine day-to-day function can oftentimes exacerbate or encourage lichen planus to form along that trauma or occlusal line site. Here you see concurrent reticular and punctate lichen planus in association with an ovoid area of atrophic lichen planus. This is more papular lichen planus. This is more common by far skin that is in the oral cavity, but papular lichen planus does occur in the mouth, and here you see that with a distinct absence of the more classic reticular or striaform lichen planus. This is more late-stage disease where we have hypertrophic or thickened mucous membrane, and this is mostly keratinized tissues. This is a pattern of reticular and erosive disease or atrophic disease, and this is classic erosive lichen planus. This is very bothersome. Toothpaste will bother this, spicy foods, salad dressings, and so forth will oftentimes be off limits to our folks with this particular form of lichen planus. Here again is another kind of a Y-shaped area. This is an ulcer that's covered with a substance called fibrin, which covers the ulcer in an attempt to form a healing plaque. And this is a lady, hold on, I just lost that. Can you still hear me, I hope? This is a lady that I've been following for some years with severe lichen planus involving the dorsum of the tongue. Are we still on? I think we may have lost that. I'll continue, however. This particular lady, this is after she's been treated. Can you hear me? No. This is the dorsum of tongue lichen planus. Let me make a call to make sure that we're still in business here. You can. Okay, fine. Okay, good. So this is a later form of lichen planus involving the tongue. Here you see the loss of tongue papillae, described a nodular, heavily keratinized disease, very different than what you see on the cheeks and the gum tissues. This is a close-up of another case of late-stage lichen planus involving the tongue. The surface is more glassy, and you lose the papillae. Here are some residual papillae here and there, but here are large, thick, heavy plaques of lichen planus as well. Again, another case of erosive or ulcerative lichen planus involving the cheek, the lateral side of the tongue, and here's a relatively mild case of lichen planus involving the attached gingiva, where it looks like a patient would have gingivitis, but in fact that's not the case. What often happens in folks with gingival lichen planus, they'll find it difficult to brush their teeth. Then they develop heavy accumulations of plaque, which make their lichen planus even worse. So you have two things going on. You've got lichen planus on one hand, and you've got plaque-induced gingival inflammation on the other. Here's another such case where you see some keratinized areas in association with eroded areas of gingival lichen planus. Again, another example of gum disease where you have a loss of, you have a gingival recession, loss of attached gingiva, what we call attachment loss, and then again, very heavily inflamed, tender, symptomatic gingival tissues. And finally, a palatal lichen planus, it's a bit unusual, but we do see it, and you see concomitant deep ulceration in association with thickened areas, as well as annular or ring-like configurations, all consistent with lichen planus. Here again is a severe case where you have palatal involvement. So, the associations and cofactors involved with lichen planus elaboration, if not causation, include drugs of various drug classes. Persistent yeast infections can produce a lichenoid reaction. Certain contact substances, certain types of dental fillings, old silver fillings can sometimes do this. Even some forms of plastic or composite restorations can induce localized lichenoid reactions. Physical trauma. Lichen planus, as with psoriasis, can respond to trauma. So if the patient has lichen planus and there's an area of frequent dental trauma, be it the cheeks or the side of the tongue, you will see lichen planus involving itself in those specific areas. And likewise with smoking. Smoking is an irritant and likewise can exacerbate or make worse lichen planus. Dental plaque is another cofactor which is very important, and I stress scrupulous hygiene in my patients, and they spend a lot of time with the dental hygienist trying to keep their teeth as clean as possible. The issue of stress is always a consideration in our patients. I feel comfortable in saying that stress itself doesn't cause lichen planus, but in many patients with existing lichen planus, stressful situations oftentimes can make it worse. So there is this stress relationship, and it probably is manifesting through the immune system, which drives lichen planus to begin with. We talked about restorative materials before, as well as this is what the pathologist will see down the microscope in a classic case of lichen planus. And if you look at this blue area, the right here, those are the lymphocytes, the T cells in particular, which are driving this and actually producing the disease. This is the reticular variant of lichen planus, where you can see this pink surface material. That's the keratin, which is the white stuff we see clinically. If you look more closely at the top layer here, where I'm moving my arrow, and the basal layer here, the lymphocytes infiltrate actually through and into the epithelium. They disrupt the basal layer, which is the layer which keeps our tissues intact and forms new cells on a day-to-day basis. It's the disruption of this basal layer which oftentimes is responsible for the ulcers and erosive lesions of lichen planus. We oftentimes would need to do immunofluorescence studies to separate lichen planus from similar diseases, especially and in particular mucous membrane pemphigoid or cicatricial pemphigoid. But in lichen planus, we see a bright yellowish green line right at the basement membrane or junctional zone between the overlying epithelium and the underlying connective tissue. Fibrin deposition is rather characteristic of lichen planus, and all other immunoreactants are negative with lichen planus, which is why this can be an important diagnostic test to separate lichen planus from other similar appearing lesions clinically and microscopically. The yellowish green bodies here are known as cytoid bodies, which are degenerative keratinocytes or epithelial cells, which are coated with immunoglobulin, usually something called IgM, which is often found in lichen planus but is not specific to it. Okay, let's talk about treatment. Lots of different therapeutic approaches to lichen planus. The cornerstone of management when lichen planus is symptomatic and must be managed are steroids, corticosteroids, cortisone-type derivatives. Dr. Rees, Dr. Burkhardt, and I oftentimes talk about topical management of lichen planus, and this is still the mainstay of most of our patients with lichen planus. Occasionally, with more stubborn lesions, we actually inject steroids beneath and around the areas of persistent lichen planus. And in severe cases, in order to gain early and quick control, we will give steroids by mouth. Depending upon the severity, the dosage can be scaled up or down. Some individuals use retinoids if patients are steroid intolerant for various reasons, and retinoids can be used topically as well as systemically. Plaquenil is an antimalarial drug that has some utility in lichen planus, as is dapsone, another systemic drug which can be helpful. More recently, we've been using drugs called cyclosporin topically, Tacrolimus, which is something known as a calcineurin inhibitor, which can be effective and sometimes can be used as a steroid-sparing agent. I do not believe that lichen planus is a surgical disease. That is to say, we don't usually cut out lichen planus and expect it not to come back. So in my experience, there is little use of surgery other than in establishing the diagnosis by way of a biopsy. There is some recent literature using certain forms of laser therapy, in particular soft lasers or KTP lasers. There may be something to this. There's an evolving philosophy of management, and maybe down the road, the lasers will be used more consistently than they are routinely today. And importantly, as I said earlier, in cases where there is significant gum or gingival involvement with lichen planus, I insist upon scrupulous oral hygiene, frequent visits to the dental hygienist, and oftentimes the use of a drug called chlorhexidine, which will also keep down plaque and intraoral bacterial burdens. So, why is oral hygiene important? And to simplify this slide, never mind really what it says in detail, but just appreciate the fact that the bacterial component in dental plaque, by way of activating the innate immune system, can likewise exacerbate or worsen oral lichen planus. So if we eliminate as best we can the oral bacterial component, we can likewise get a leg up on the management of our lichen planus condition. If we have drugs, corticosteroids remain the mainstay. Retinoids far less likely, and plaquenil or hydroxychloroquine is another non-steroidal alternative which can be useful in some patients. Other treatments, as I said, topical tacrolimus, a drug called Protopic, in various strengths can be used rather effectively. Azathioprine, which is a chemotherapeutic drug, in the past has been used. I don't use it any longer. I think the toxicity of this is significant. So I kind of left this along the wayside. I no longer use azathioprine. Laser ablation, as mentioned earlier, does have some increasingly useful role in the management of lichen planus. I will often use drugs in the tetracycline class, in particular with significant gingival disease or gum disease. Doxycycline, minocycline, in my hands, has a role, and this has to do with a certain molecular collagenase activity at the basement membrane zone. The literature talks about the use of a drug called phenytoin, which in my mind has no utility whatsoever. And likewise, a drug called interferon has been used in the past, but I find little utility because we have far less expensive and more effective drugs than the latter two. Topically, steroids by all means. Protopic, which is a calcineurin inhibitor. Antifungals may have a role here in reducing yeast burdens in the mouth and likewise concomitantly improving the response to our more typically used drugs. And likewise, chlorhexidine, I think, has a role to play because there's a very effective and inexpensive topical antibiotic, which is a prescription drug. What we need to do in the ultimate, is reduce the activity of the T cells, which are really driving this disease. One of those drug classes that are used to reduce T cell activity is Tacrolimus, which was developed initially for use in the transplant patient. But topical tacrolimus is effective for many immune-driven skin and mucous membrane diseases, including eczema and now lichen planus as well. We use ointments. I generally use 0.1% tacrolimus. It's effective. In some studies, it is shown to be as effective as steroids. That's quite possible, but I oftentimes will use both concomitantly as a steroid-sparing effect. There's a fairly recent study in the dermatological literature which uses very, very low concentrations of tacrolimus in a aqueous or water solution. This was a study by Olivier and her colleagues published in the Archives of Dermatology some years ago. I will use it on occasion, but I think this drug, while it is the same as tacrolimus ointment, it's very, very diluted in almost homeopathic doses. And tacrolimus cream, something called pimecrolimus or Elidel, has a role to play as well in a similar fashion to Protopic. And finally, the last subject to cover before we open this up to questions is a question I get all the time from my patients. Can this be related to cancer? And the answer is yes, but we're talking about a relatively small number of cases. So yes, the 800-pound gorilla remains. Is lichen planus a pre-malignant condition? In a small percentage of cases, I think you have to say yes. And what seems to be driving that is the long-term presence of chronic inflammation, which can act as a transformational factor in leading to precancer, if not cancer. So important in the entire equation here is continued follow-up by your management team for oral lichen planus to make sure that it remains as lichen planus only and nothing else. So while it is somewhat controversial in my hand and in my mind over the last nearly 40 years of practice, I believe that lichen planus must be followed for that reason alone, if not for no other reason. We have various forms of lichen planus, but in particular the erosive and atrophic forms are those types which tend to transform rather than the reticular type, which in my mind, and I've never seen that happen, does not occur. The duration of lichen planus can be decades, but it's usually in the longer term cases where you see this transformation occur. And as I said earlier, and repeating myself, the reason for this transformation is probably persistent chronic inflammation and relating itself back to what we call DNA mismatch repair, where cellular repair and healing doesn't occur normally, and it leads to dysplasia and precancerous conditions. So this is an evolving area of study. We are certainly able to recognize this disease. We have diagnostic parameters which are well defined at this point. We have clinical algorithms which can be very effective in management, and we certainly appreciate the relationship of cancer development in a very small percentage of cases.
Jim, I've received a three-part question from an individual whose mother has biopsy-confirmed lichen planus. It's been successfully treated, and she is now under control, but she's going to be returning to her native country where she won't really have very knowledgeable encounters with dental health professionals. And so part one of the question is, she's been told to start treatment if she starts to develop recurrent lesions. And so the question is, how can you identify early signs of lichen planus?
Well, yeah, that's a good question. The patient certainly has experience at this point as to what the abnormalities are. Asymptomatic lichen planus is oftentimes disregarded by our patients or forgotten about. I just think a keen eye and routine examinations by the patient with a good light and a good mirror should keep them pretty much on top of any subtle changes that may be occurring. And I would tie that to any symptoms that may be evolving at the same time.
Okay, excellent. I totally agree with that. The next question, same individual. When the patient was biopsied, she had some candidiasis in the biopsy site. So the question is, how does she know if she's getting a recurrence of her candidiasis, which has been successfully treated as of now?
That's a good question. Many times people will carry candida or yeast organisms in their mouth as just part of their being. Many people are carriers. In fact, the majority of patients do carry candida. I guess the question in that equation is, does the presence of candida in Lichen Planus tend to make Lichen Planus more persistent? If my biopsies show Lichen Planus along with candida concurrently, I will treat the candida with topical or even systemic antifungal drugs.
Again, I totally agree with what you just said. I think that since we use so many topical steroids, that we kind of predispose patients to a secondary candidiasis resulting from the treatment, and we have to be aware of that and on guard against it. And
I agree 100%, Terry. Absolutely right.
And the third question third component has to do with the concern about possible malignant transformation, and how much of a risk is that? I think you've already answered that it's apparently a very small risk if it is a risk. But what are the early signs of malignancy that his mother should be looking for?
That is a very good question, and it's not an easily answered question, in that early stages of cancer or dysplasia sometimes look similar to atrophic Lichen Planus, where the area is deeply red or even a little bit velvety, or there may be some textural surface changes that you can appreciate, or a persistent ulcer, or when you run your finger over or your tongue over the area, it tends to be thick or indurated. Those are some of the signs that I would pay attention to as perhaps heralding transformation, if not frank cancer development.
Thank you.
Yes. May I just add one thing to that? I think that there are some good videos and CE courses that are online that give the patient an idea of what to look for in the mouth with any abnormality, whether it's Lichen Planus or anything else. And retracting the tongue, sitting in front of a makeup mirror, using good lighting, as Dr. Sciubba just said, and really looking at getting used to what is normal and what is not normal. I think if you go online, you can find some of those. If you have trouble finding them, email me and I will send you a link.
Great.
Okay, we have a question here. The questioner says, I haven't found any toothpaste that doesn't cause my mouth to burn. Recently, I dropped using toothpaste entirely, but am worried about whether there is a downside to my overall dental health. I thought about using baking soda, but have read that it's too abrasive for everyday brushing. Your thoughts are appreciated.
Okay, I can start with that. I'm sure Terry and Nancy likewise have opinions. Yes, toothpaste can be a problem. Many of the commercially available toothpaste with the flavoring systems and the detergent systems within them can be bothersome. Some people like to use Biotene toothpaste and products, which is a rather bland toothpaste, but Glaxo has changed that formulation, and some people are now bothered by the use of Biotene, but Glaxo was looking into that. I just had a conference call with those folks a week or two ago, and they're re-examining it yet again. I oftentimes will have my patients use a children's toothpaste, which has much milder flavoring systems in it, less detergent, as another alternative. I would continue to try to find things that would be helpful to you. Yes, baking soda can be abrasive. You don't want to be using it every day. There's a role for it, but I would for children's toothpaste to start with, and buy 2 or 3 different kinds to see which one can be most effective. And even between meals, you may want to use a toothbrush that you soak in fluoride rinse that is available over the counter, an ACT mouth rinse, which doesn't contain alcohol, soak your toothbrush in that and use that as a help. You get your fluoride, and you can remove your plaque at the same time.
I agree again with everything you've said, and to my way of thinking, the catchphrase here is that she stopped using a toothbrush, and I think that the evidence shows that that is detrimental to not only to your overall dental health, but to lichen planus as well if the gum tissue is involved with the lesion. So I think it's really important to find a toothpaste that doesn't burn. And that's our cardinal rule. If it burns, don't use it. And sometimes you do have to experiment a little bit with the children's paste. For example, there's one, and I'll go ahead and say it, Crest, that has cinnamic aldehyde in it, which is an irritant sometimes for some patients, even in the children's formula. But some of the others, major caries, don't have that.
Agreed.
I'll add something to that. As Dr. Sciubba just said, sometimes patients will stay away from the tissue because it will get so ulcerative and irritated. So finding a very soft bristle brush that you can use at those times is really very important. And I know that biotin did make a really soft one, and Dr. Reese and I were just talking about this yesterday. So we're hoping to locate that brush again, and there are some that we can recommend that are very soft, but the whole idea is to keep the area very clean and plaque-free, as Dr. Sciubba had just said.
Okay, a questioner said that there was a recent study showing that there was quite a bit of improvement using purslane. Would you care to comment on that?
Yeah, purslane is a common household plant. You can grow it indoors, and in warmer weather it grows outdoors very nicely. In fact, we had some in our garden this year. The purslane study was, I think it was generated from Tehran. One patient of mine actually bought some purslane and used the leaves of the purslane kind of as a mouthwash. There may be some beneficial effect of it, but I think we have better things available.
Okay, a questioner asks if you've heard of using antibiotics and niacinamide to successfully treat oral lichen planus.
The role of niacinamide and antibiotics in particular has been used for the management of mucous membrane pemphigoid. That was originally shown in the ophthalmology literature some years ago. There may be some utility with that, in particular tetracyclines and niacinamide, but oftentimes the niacinamide has significant side effects in terms of flushing, liver enzyme elevation. You've got to be a little bit careful with that particular drug in high concentrations on a consistent basis.
Jim, you mentioned that you have some success for gingival lichen planus using minocycline.
Yes, I do.
Tell us how you use that. How do you administer it?
Yes, I like minocycline or doxycycline low dose. I start with 50 milligrams twice a day, and once I get it controlled, I'll back down to periostat at 20 milligrams twice a day. And the reason I find that effective in many patients, but not all, but many, is that we tend to derail the destruction of the basement membrane zone by the enzymes that are elaborated as part of the inflammatory process. So we unhook the collagenases by shutting down some of the matrix metalloproteinases, which are inhibited by the tetracyclines.
Thank you.
A questioner asks, can OLP be transmitted to another person generally?
No. We get this question a lot, and it's usually the person in the middle of the night that's emailing and concerned about it. But no, you cannot infect another person. You didn't get it from anyone. You can't give it to anyone. And contagion is always a question that we've had from the very beginning. And it's something to be concerned about, but we can usually alleviate your fears in that regard. Maybe Dr. Sciubba might want to comment on the candida. Now, that being transferred to another person. Usually it involves the immune system, so probably not, but we have heard of cases.
Well, yeah, I don't know the specifics about transmission of Candida. I mean, it's got to come from somewhere. You're not born with it.
Right.
You become colonized fairly early in life. So yes, it comes from someone and somewhere. So theoretically, you can transfer Candida. I'm not suggesting you don't kiss your mate or your loved ones and so forth, because it is part of our being as organisms that we're going to carry Candida and staph and other organisms as part of us being what we are.
Thank you.
Okay, my OLP has now become erosive under my tongue on both sides, very painful. Could my plastic mouth guard, which is for sleep apnea, have caused or exacerbated this condition?
It's possible it may be playing a role, in particular if the tongue has been traumatized by the CPAP, by the device, by the sleep apnea device. Yes, we know that Lichen Planus can be exacerbated by local physical trauma. I doubt very much that the plastic itself is involved as a topical allergen, but I would place more of the role on maybe the traumatic aspect. I would have the dentist make sure that the edges or margins of that appliance are smooth and highly polished and well contoured to eliminate that particular possibility.
A patient near Dallas wants to know if you're taking on new patients, so maybe we.
Wants to know if Dr. Sciubba's taking on new patients?
Yes.
If you want to travel to Baltimore.
Well, we have placed patients with Dr. Sciubba in Baltimore that are in that vicinity. So.
Okay. All right. Well, maybe you have some discussion that you'd like to carry with Dr. Sciubba. I think we're getting down on the questions, and if anyone has any more questions, you can go ahead and submit them now. We're getting close to the end of the session. So,
Jim, you talked about the response to treatment and the various the early recurrence. What I tell patients is that since we don't know what's causing lichen planus, we're treating symptoms. We're not treating the etiology of the condition, and that they will have a recurrence. But that as long as it's painless in the reticular form or maybe the small areas of plaque-like form, that's okay. But when they have discomfort is when they should seriously consider using the effective treatment that they have for a few days to get it under control. You agree with that, or would you amplify on that?
Yeah, I agree with the philosophy, Terry, for sure. What I do with my lichen planus patients, those folks that are being treated by one means or another, I will follow them, clearly, unequivocally. Those folks that are asymptomatic and have reticular disease only, I oftentimes return them back to their referring doctor, usually their dentist, to be evaluated. If they choose to come back to see me on routine follow-up, that's fine as well. But I do believe that they should be followed by someone who understands a bit about the disease and separate this from what normal mucosa looks like.
Right. The only thing I'll add to that is, especially women, Dr. Sciubba had mentioned the vaginal aspect, and sometimes these patients get lost in transition. They may be seeing a gynecologist, but the gynecologist doesn't know about the lichen planus orally, and maybe the dentist doesn't ask about any vaginal lesions. So that connection is often lost, and that I think needs to be strengthened. But for women, they need to make sure that both parties know what's going on. And also, Dr. Sciubba in his presentation had mentioned the esophageal connection too. We do get quite a few emails from patients who may think that they have esophageal lichen planus, and we suggest that they go to their ENT person and get that evaluated and checked, because it can occur in any lining mucosa.
Agreed, Nancy. So the two subspecialties that we're talking about here is otolaryngology, the ENT doctor, and the GYN person. I think it's important for those folks who develop some swallowing issues in the face of oral or acute or skin lichen planus to be sure that it's esophageal LP, which is a very difficult type of LP to treat, and also has to be separated from Barrett's esophagus and other things that can produce similar symptoms, in particular difficulty swallowing, dysphagia, etc. As far as the GYN aspect of this is concerned, in my intake exam, if the patient either comes with a diagnosis of lichen planus or we prove the diagnosis, make no hesitancy about asking the question about GYN complaints, anorectal itching or symptomatology. And if the answer is yes, you bring the GYN practitioner into the fold and indicate to the patients that this is not a mystery. There are means of controlling the vaginal LP just as we can control oral LP. And we oftentimes will discuss this with the patient's treating gynecologist.
Oh, that's a really good point. And sometimes women suffer needlessly for years, and as long as that goes on, the scarring gets worse, and it just complicates things.
Scarring in late stage vaginal lichen planus, definitely introitus problems, all kinds of issues, interpersonal issues that in a marriage and a relationship also can be affected. I think that many women will come to us and say, well, yes, I get yeast infections all the time, vaginal yeast infections, and in fact, it's not vaginal yeast at all, it's lichen planus, because the itching is common to both conditions. Right. So that's why the gynecologist has to be involved.
Right. That's a really good point. Thanks.
Yeah. Okay. I want to remind everybody, thank you, Dr. Sciubba, by the way. This has been fantastic. Our first Skype session, Dr. Sciubba was one of the first people to join us on our old just chat room, typing it all. And so it's been great to have you this morning with us and everyone else here with us. I want you all to realize that after the session is over, the recording will be here on the live stream site for about, 3 or 4 weeks afterwards. But we will be taking the recording and moving it to our website. So please keep an eye out for that. Also, the questions that have not been answered yet, we will do our best to deal with by email. And you can check back here. Underneath the video screen is the comment section, and participate in the chat as time goes on. So I want to thank Dr. Rees, Dr. Burkhart, and again Dr. James Sciubba for joining us on this segment of webcasts from the International Oral Lichen Planus Support Group at Texas A&M University, Baylor College of Dentistry. We'll see you all next time. Bye now.
Thank you. Thanks, everybody.
Thank you very much.
Terry, take care, folks. See you soon.
Thank you.
Okay, bye-bye.
Bye-bye.